Today we're going to talk about Truncus arteriosus, otherwise known as Truncus arteriosus communis or common arterial trunk. First, let's start with a pretest. This is a question from the CSAT's cardiothoracic surgical exam. So the scenario is an asymptomatic 9-day-old 3-kilogram boy is found to have Truncus arteriosus on evaluation of a murmur. An echocardiogram demonstrates a quadricuspid truncal valve with a flow gradient of 35 millimeters mercury and mild insufficiency. The pulmonary arteries arise from a common trunk. There's a large outlet ventricular septal defect. Which of the following statements regarding this patient is correct? A. Elective repair should be scheduled between 3 and 6 months of age. B. Mild hyperventilation, down to a PCO2 under 35, should be maintained during transport to the operating room and induction of anesthesia. C. Non-irradiated blood is acceptable for transfusion in this patient. D. Truncal stenosis is likely to be overestimated by echocardiogram. Or E. A truncal valvuloplasty should be performed to convert the quadricuspid truncal valve into a tricuspid valve. We'll come back to this question at the end of the talk. So first, let's talk about the anatomy of Truncus arteriosus. Truncus arteriosus is characterized by a single great artery arising from the heart, which goes hand in hand with a single semilunar valve. And that single great artery arising from the base of the heart gives rise to the coronary arteries, the pulmonary arteries, and the aorta. This truncal artery overrides a ventricular septal defect, so the VSD is typically an outlet VSD coming right up to the base of the heart, right up to the semilunar valve. There really isn't a conal septum because that only forms because there's separation of the two outflow tracts into two semilunar valves separately. And that isn't the case, obviously, with Truncus arteriosus. The truncal valve is a single valve, and it may have between 2 and 4 cusps, sometimes more, but some studies have shown that up to 70% of truncal valves are actually tri-leaflet. And Truncus arteriosus is relatively rare, making up 1 to 2.5% of all congenital heart defects. Truncus arteriosus may have associated defects that go with it. We worry a lot about interrupted aortic arch, and we'll explain why we worry about that later in the talk. But about 10 to 20% of patients with Truncus arteriosus will also have aortic interruption. The aortic arch may be right-sided in up to a third of the patients with Truncus arteriosus. It's an interesting but physiologically unimportant finding that Truncus patients don't have a ductus, with obviously the exception of patients with an interrupted arch who have a ductus feeding the descending aorta. There may be truncal valve stenosis or insufficiency. The valve is often unusually formed, and that may result in abnormal function of the valve. Coronary anomalies have been described in various studies between 5 and 20% of patients. Unfortunately, as I've looked at a lot of this literature, the specific details of coronary anomalies usually aren't described in these papers. So the coronary anomalies that I think people are referring to are either takeoffs of the coronaries, maybe a little bit out of the sinus of Valsalva, so in a position where it may be at risk to damage the coronary ostium when you're taking the pulmonary artery and aortic components apart. Or the branching of the coronary arteries may be unusual, and that may have some influence on selecting a site for a ventriculotomy on the right ventricle where you may want to originate your RV to PA conduit. And then in a small percentage of patients, there may be stenosis or hypoplasia of the pulmonary arteries themselves. And then DiGeorge syndrome, or a 22q11 deletion, is seen in a third of patients with Truncus arteriosus. If we look specifically at the subset of patients with truncus and an arch anomaly, such as interrupted aortic arch, the incidence of DiGeorge syndrome goes up as high as 85%. There are a couple of classification schemes that have been described for Truncus arteriosus. The Collett and Edwards scheme was first reported, and then later von Prog's reported a similar but somewhat different scheme that's subsequently been modified to what most people rely on now. And the type 1 truncus usually refers to the fact that there's a main pulmonary artery segment that comes off the truncal root before bifurcating into left and right components. That's fairly rare occurrence. Often what we see is what's seen in the bottom left panel, where it's sort of a hybrid between a type 1 and a type 2, where the branch pulmonary arteries come off adjacent to each other. Along the left side, there may be a little segment of main pulmonary artery, but along the right side, it's really the right pulmonary artery coming directly off the truncal root itself. And type 4 usually refers to the interrupted aortic arch in the von Prog's classification. So first, a little bit about the history. Truncus arteriosus was first described in the late 1700s on a postmortem examination, and about 75 years later, Buchanan was the first person to document a clinical description with later autopsy confirmation. The Collett and Edwards classification that I mentioned on the prior slide was first proposed in 1949, and it was in 1962 that Sloan from the University of Michigan, go Blue, performed the first successful repair. It actually was not reported right at that time. It was actually cited in a later report from the University of Michigan on experience with truncus, but that's retrospectively people gave credit back to Herb Sloan for having performed the first successful repair. The von Prog's classification came out shortly after that, and remember, this was still in the early days of open heart surgery. Early 1950s was the advent of heart-lung bypass machines, and so in the 60s, these were older patients that were really undergoing open heart surgery, not newborns as we would currently predict. In 1967, at the Mayo Clinic, Magoon and Rastelli described a repair using a homograft conduit to reconstitute RV to PA continuity. And then a real landmark in the history of Truncus arteriosus was Paul Ebert's experience, which spanned a decade between the mid-70s and mid-80s, where he reported a 90% survival of over 100 patients with Truncus arteriosus, all repaired under the age of 6 months. So really, before the advent of a lot of newborn heart surgery, experience with a very young group of patients with excellent survival, really a leap forward. And to give due credit, Paul Ebert was an Ohio State grad, so the Michigan-Ohio State rivalry goes beyond the football field into the realms of the history of Truncus arteriosus as well. So the physiology and how do these kids present? This is a complete mixing lesion. Obviously, blood coming back from the lungs, blood coming back from the body, all gets mixed together at the level of the ventricular septal defect, because there's only one way out of the heart through the common trunk. And so oxygen saturations may initially be low, largely depending on the amount of pulmonary blood flow, which in the first hours of life may be normal to on the low side as the lungs expand and pulmonary resistance falls. But with that fall in pulmonary resistance, we have an elevation of pulmonary blood flow, so resulting relatively high QPQS situation with oxygen saturations that are near normal. or only mildly decreased because of the excessive amount of pulmonary blood flow. And then with that, over several weeks, congestive heart failure symptoms are expected to develop. We may see a wide pulse pressure due to systolic and diastolic runoff into the pulmonary bed. And if the patient has DiGeorge syndrome, there's a risk of hypocalcemia because parathyroid insufficiency is associated with DiGeorge, and these kids are physiologically stressed, which we know has a exacerbating effect on the tendency to hypocalcemia, and that may result in hemodynamic instability or even collapse if severe enough. The natural history of truncus arteriosus is depending on two of the aspects of this pulmonary overcirculation. One is there's an elevated risk for systemic low flow complications. A lot of runoff to the lungs is going to potentially result in compromise of blood flow to the rest of the body, and necrotizing enterocolitis has been reported frequently in children with truncus arteriosus. And then because of the excessive pulmonary blood flow at systemic pressures, the accelerated development of pulmonary vascular occlusive disease is well described. Historically, untreated survival with truncus arteriosus was only about 50% at a month of age, and dropping down to less than 20% by 6 months of age, and then tapering off. The kids that survived that long usually had some balance in their physiology for whatever reason, and there was a slower drop-off, but still high mortality in the first year of life historically. The evaluation of truncus arteriosus, as with many congenital heart defects, hinges mainly on echocardiography. It will demonstrate the great vessel anatomy, usually the takeoff of the great vessels, important to identify whether there's an interrupted aortic arch. The great vessel anatomy can look very confusing by echocardiography in cases with interrupted aortic arch, because there's this one vessel that leaves the heart, but then it divides up into branches that can look very confusing by echo. The presence of the VSD obviously can be well demonstrated with echocardiograms. The function of the truncal valve, a lot of times we can get a sense for dysplasia of the truncal valve, how many leaflets of the truncal valve, but most important is the function, whether it's importantly stenotic or importantly regurgitant. And then sometimes by echo we can get a sense if there's major abnormalities with the coronary takeoffs or their courses. Three-dimensional imaging, CT or MRI, can often be helpful for demonstrating the great vessel anatomy, particularly in cases where that great vessel anatomy may be confusing, such as the cases with associated interrupted aortic arch. Genetic testing is important. It's important to send it off early before these kids are transfused, and sometimes a CMA or chromosomal microarray is sent off, but the turnaround for those is pretty long. Often a targeted FISH study for Q22 or 22q11 deletion can come back within a number of days to confirm the presence of DiGeorge syndrome. And then from an endocrine standpoint, it's important to monitor calcium levels in the first days and weeks of life in these children, because they will have a tendency for hypocalcemia, particularly the kids with DiGeorge syndrome, obviously, but even stressed newborns without DiGeorge may be at risk for hypocalcemia. And so here we see a parasternal long axis view of the heart demonstrating some of the important features of truncus on echocardiograms. We see the left ventricle, the right ventricle, the interventricular septum with a large defect in the outlet portion of the septum just below the single semilunar valve. The leaflets appear a little bit dysplastic. And then tipped a little further toward the outlet, we see again the truncal valve giving rise to a single great vessel with a continuation of the aortic component and an early takeoff of the pulmonary artery component. So this demonstrates some of the features as seen on three-dimensional imaging. So again, left ventricle, right ventricle, outlet defect, single great vessel arising, giving off aortic and pulmonary artery components. And the three-dimensional reconstructions can demonstrate the anatomy often even better, particularly the branching of the great vessels coming off the base of that single truncal vessel. And this demonstrates the complexity that we'll often see with an interrupted arch with a truncus. So we see a single truncal vessel, the ascending aorta only giving off the first arch vessels. The main pulmonary artery component is quite a bit larger, giving off branch pulmonary arteries, but also the ductus, which gives rise to the descending aorta, with the left subclavian artery arising with the descending aorta from the distal segment. So very complex appearing great vessel anatomy with truncus interrupted arch. So the management of truncus arteriosus has obviously changed over the years with the advent of open heart surgery. The opportunity to perform a complete repair was then possible. But it's interesting to look back in the textbooks. The first edition of Natus Pediatric Cardiology, which was published in 1957, spoke in the brief paragraph on treatment of truncus arteriosus that only medical therapy, antibiotics, and anticongestive measures is available for patients who have an adequate pulmonary circulation. If, on the other hand, pulmonary arteries are small or defective, a shunt procedure may successfully be performed. It must be remembered, however, that the operative mortality is high, the number of satisfactory results are few and far between. Consequently, surgery is to be recommended only for cyanotic patients in this group whose limitations are really maximal. The same textbook now, a number of years later, in 1992, as we're starting to get into the era of newborn heart surgery, tune has changed a little bit, but still actually not reflecting current practice. At the Children's Hospital in Boston, our present policy is to attempt to manage the baby medically for the first months of life. Thereafter, surgery is performed as soon as there is evidence of failure to thrive, and at the latest by 6 months of age. So recommending early medical management, waiting for the children to develop congestive failure, which, as we know, would often happen in the first weeks or months of life, but waiting for that to come about before recommending surgery. Historically, this is back from Ebert's landmark publication with his first 10 years experience, looking at the age distribution of presentation, as these kids would be presenting in the first months of life, as one would expect, with a peak age at presentation about 3 months of age with the onset of congestive heart failure. But currently, the management of these children surgically is almost always performed during the newborn hospitalization. With the advent of regular newborn open heart surgery beginning in the early 80s and continuing into the 90s, there really is no advantage to waiting for these kids to get older, just increased risk of morbidity and mortality the older they may be. And so the surgical correction of truncus arteriosus involves separation of the pulmonary arteries from the truncal root. So the truncal vessel will be now repurposed as the proximal aorta. The ventricular septal defect is closed, baffling left ventricular flow to that single semilunar valve and out to what is now the systemic blood flow, the aorta. And then reconstitution of a new connection between the right ventricle and the branch pulmonary arteries, which have been separated from the truncus, usually using a valved conduit of homograft or other materials. With interrupted aortic arch, you have to get a little more inventive. So there's a number of techniques that have been described. Here's an example of one where the pulmonary bifurcation is removed from the truncal root. The ductus has been excised. So we have a descending aortic segment. We have a small ascending aortic segment beyond the takeoff of the pulmonary arteries that can be opened up further, and then reconnection of the descending aorta to the ascending aortic segment, often requiring some patch augmentation to reconstruct a neo-aorta. And then again, VSD closure and construction of an RV to PA conduit. In the case where the truncal valve is severely dysplastic and regurgitant, there have been descriptions of repair of the truncal valve as part of the newborn correction, and this slide demonstrates one technique where if a leaflet of the valve is small and dysplastic and responsible for the regurgitation, it can sometimes be excised and the truncal root reefed up and made smaller to result in a more competent truncal valve, but not routinely recommended just on the basis of dysmorphism of the valve. A 4 leaflet valve doesn't necessarily need to be changed to a 3 leaflet valve. A 4 leaflet valve may be functioning just fine and do so for many, many years. So what are the outcomes? The overall survival, and this is a long-term follow-up study published from the UK with 40 years experience, going back to their initial experience with Truncus arteriosus up through the current decade, with about 80% survival long-term. So just like one might have expected after reading Paul Ebert's initial success with surgical correction, once we got these kids successfully corrected early in life, the long-term survival is expected to be quite good. Risk factors for bad outcomes have been reported. This is from a paper documenting Boston's experience during the early years of newborn repairs. So some of these kids were repaired right in the newborn period, but some a little bit later. And this paper identified 4 risk factors for decreased survival. One was interrupted aortic arch, not surprising. One was severe truncal insufficiency, which again ultimately led to people's attempts to try to manage that in the newborn period. Coronary anomalies were noted to be a risk factor, although in the paper, again, they don't really describe what was anomalous about the coronaries that led to poor outcomes. And then repair later than 100 days of age. This was a period of time, again, where some of these patients were either presenting late, referred late, or electively delayed until they developed significant heart failure symptoms, and presumably the increased mortality associated with older age was a reflection of the advent of pulmonary resistance changes, either fixed pulmonary hypertensive changes or the tendency to develop severe pulmonary vasospastic crisis in the perioperative period. When we look at interrupted aortic arch and tricuspid or Truncus arteriosus, their survivals have always been far less than what we would refer to as a simple Truncus arteriosus. This was from a registry study by the Congenital Heart Surgeons Society. It was an interrupted aortic arch registry. They pulled out the subgroup of 50 patients that had Truncus arteriosus associated with the interrupted aortic arch, and they did see a bit of an era effect. The results were frankly lousy in the earliest cohort, 1988, with a 20% survival, improving as things moved into the 90s with a 40% survival. And as you can see from this graph, most of the mortality, as one would expect, was early in the first year of life, typically perioperatively. What about durability of the right ventricle to pulmonary artery conduit? We're having to use replacement parts to reestablish RV to PA or to establish RV to PA continuity. Usually homograph tissue has been used, and not surprising, when you put a valved conduit in a newborn, they're going to outgrow it. And by 10 years of age, almost everybody's outgrown their newborn conduit. Not a surprise. And it's almost a linear function from the time of initial operation over the first decade of life for the rapidity at which they outgrow these conduits. What about the truncal valve itself? Truncal valve durability is actually quite good, partly depending on how good the valve is when you start. So if we look at the middle line, all patients, freedom from truncal valve replacement out to 15 to 20 years is about 60%. If the valve was not insufficient, so it was a competent valve before the initial repair, 90% of those patients will still have their native valve out 15 and 20 years. Pre-repair truncal insufficiency, as one might expect, is a major predictor of the need for truncal valve replacement later in life. And as you can see from the graph, there's a slight drop-off or a slight risk for need of truncal valve repair in the first couple years of life, and then things level off a little bit, but then out to 10 to 15 years, things start to drop off again more precipitously as kids get a little bit older. And so let's go back to that initial question. Again, an asymptomatic 9-day-old 3-kilogram boy is found to have Truncus arteriosus on evaluation of a murmur. Echocardiogram demonstrates a quadricuspid truncal valve with flow gradient of 35 millimeters mercury and mild insufficiency. The pulmonary arteries arise from a common trunk. There's a large outlet ventricular septal defect. Which of the following statements regarding this patient are correct? So A, elective repair should be scheduled between 3 and 6 months of age. And again, what I've explained is that this had been a fairly common practice previously, but in the current era, we would typically recommend elective truncus repair in the first hospitalization, usually toward the end of the first week of life, assuming there are no contraindications to proceeding with repair. Choice B, mild hyperventilation should be maintained during transport to the operating room and induction of anesthesia. The concern with hyperventilation is it will only decrease pulmonary vascular resistance and exacerbate the what may be severe pulmonary overcirculation and result in systemic underperfusion and potential hemodynamic instability at a time just before placing a child on cardiopulmonary bypass, which could have dire consequences. Choice C, non-irradiated blood is acceptable for transfusion in this patient. Typically not. Usually by the time that children are going off to the operating room, we've not yet had the results of the chromosomal analysis back. You have to assume that these children are DeGeorge unless proven otherwise, and with DeGeorge syndrome, these children are athymic. The risk of graft versus host disease when they're transfused with non-irradiated blood is present. So it's typically recommended that we irradiate all blood in these patients, and certainly once they're shown to be DeGeorge, if that's the case, that they will maintain that directive to the blood bank in the future. Choice D, truncal stenosis is likely to be overestimated by the echocardiogram. Because that truncal valve is accepting the full systemic and pulmonary cardiac outputs together, and as the pulmonary resistance drops, that total cardiac index may be 3, 4, 5 times a normal cardiac output. It's not surprising that a gradient can be seen at that valve, even if the orifice of the valve is quite acceptable, and a gradient may be simply on the basis of elevated flow and not true stenosis of the valve, so that quite often what may seem like a significant gradient that would be associated with important valvar stenosis is really simply an overestimation because of the excessive amount of flow. And after repair of the truncal anomaly, with the fact that that valve will now only have to handle systemic output, the gradient simply goes away. And then the final option, truncal valvuloplasty, should be performed to convert the quadricuspid truncal valve into a tricuspid valve. No, not as a routine, only a consideration if there's important truncal valve insufficiency. And so, as we just explained, the correct answer in this question is choice D. Thanks for your attention.